Well, it is at the top of the hour, noon Eastern time, and I want to welcome everyone to today's webinar, How to Quantify the Impact of Social Determinants of Health. We have a fabulous webinar with a very, very full agenda and some fantastic speakers. We've got Ben Isgur from the Health Research Institute at PwC, and we've got Sam Burns, who is the Emerging Technology Director. He leads PwC's Artificial Intelligence Accelerator. We've got Chris Culak, who is the Vice President and Chief of Strategy and Development for the Visiting Nurses Association of Texas. And we've got Shazeb Matthew, who is a modeler on PwC's Bodylogical team. So a really fabulous group of presenters today talking about social determinants of health. And it's become such a key issue today. So we're thrilled to have these presenters. We're going to hear about PwC's report, The Urgency of Addressing Social Determinants of Health. We've got also someone talking about the 5 key steps for health systems in using social determinants of health. And then we've got the case study. So really, really pleased that you're able to listen in to these fabulous presenters. And here are the photos of everyone, Ben, Sam, Chris, and Shazeb. But before we get started, just a few housekeeping tips. All of the participants are muted. We've got 2 boxes to look at. We've got a Q&A box. So when you have questions, please use the Q&A box. We've also got a chat box, and sometimes it's easy to confuse the two. Don't ask questions in the chat box. If you have any technical difficulties, that's where you would reach out to me or Ali on my team, who's helping to manage this webinar today. And Ali's also going to be sending you the presentation. EHI has been around for, my goodness, 20 years now. We serve as the industry leader in convening executives, identifying best practices through the use of technology and innovation. Currently, we've got some 4 key areas that we're working on with value-based care, interoperability, privacy and security, analytics, and as of today, social determinants of health. We've done a lot on social determinants of health, and you can find some white papers and other research information, and also copies of some summaries of some of the executive roundtables that we've had on social determinants of health. So when you have a chance, take a look at our EHI Resource Center. So EHI works with numerous people. We've got our members. We also work with numerous people on webinars such as this, on our executive roundtables, payers, providers, researchers, and we do this, through these different formats of the webinars such as today, and internal meetings for our EHI members, our conferences and meetings. Also, just to take a quick look at our leadership council, this is a smattering, a sample of many of our leadership members. We're really thrilled and very proud to have such a fantastic group of people that serve to provide some direction for our organization. But we also have events and meetings, and please take a look at our event page. We've got a meeting coming up on February the 4th, which is totally in line with what we're talking about today, working with government to advance social determinants of health. It's going to be in Washington, D.C., and you can go to our website and register. We'd love to see you there. The idea is to find out what's going on in the payer-provider world, as well as the federal and state initiatives to support social determinants of health. And if you're going to be at HIMSS, please join us. We're going to be sending out an invitation this week, and we look forward to seeing you in Orlando. So these webinars and other meetings are not able to be conducted without the generous support of organizations and companies such as PwC. So we thank PwC for their support. And on that note, I'm going to turn this over to Ben.
Well, thank you so much, Claudia, and we're very happy to be here talking about what we think is one of the most important issues, not just for the health system, but for our time and our communities. And it's one of the reasons that we chose to embark on this, this research project over the last year and look at it not just from a US perspective, but also from a global perspective. So let's go on to the next slide. I'll just tell you just a little bit about our research. And the great thing about this webinar is that we're going to take you from the macro. So how is this affecting organizations and communities and cities and populations kind of around the world? And we're going to bring that down into kind of a sharper and sharper focus, where we're going to end up with a case study on how one organization is using this to great effect here in the United States. And so I think it'll be a real treat to kind of work through that with us as we go from the macro to the micro. So a little bit about the report on the next slide in terms of, you got a great group, of course. If we can go on to the next one, please. A little bit around our report on the next slide, just in terms of where the research comes from, so that you all can have a comfort level of when you're looking at some of this data, where did it come from? How did we get it? So we actually conducted a global consumer survey this last year, a little bit over 8,000 consumers. We tried to have a good mix of territories around the world, and you can see here that we have different geographies, different countries in terms of economic wealth, just a good broad group of to better understand what consumers are thinking and how they're being affected. We also did a round of executive interviews to produce the case studies that are in the full report. As we look at social determinants. So moving on, let's kind of look at the major question we think of our time, which is, if the world is getting wealthier, why isn't it getting healthier? And we've had a very nice period over the last 50 years where we've seen average lifespans increase. A lot of that, of course, is due to better public health and things of that nature. But we've got some kind of troubling data now that maybe some of those great strides to improve health are starting to slow down and potentially even reverse themselves. One metric that a lot of researchers will look at is the rising obesity epidemic. I think many of you on this call have seen this and thought about this and heard about it, but it is interesting when you kind of see the numbers there and the fact that we are starting to tick up in terms of the percentage of the population that falls into these categories. And when we projected this on out to in the full report, you can see you'll see a data point out there all the way to 2025, and of course it's really continuing to increase over time. Now, why is that such an issue? Well, this biometric issue is one of the precursors to chronic disease that we see, diabetes, COPD, and other diseases that are now afflicting many people around the world, and really getting to the heart of how we're being challenged around the question of why aren't we getting healthier, even though in many cases we are in much wealthier areas. Well, that question in fact has been answered, and on the next slide we kind of get to the heart of what the challenges are. A lot of our focus over the last 50 years has been around clinical care. Certainly for those of us sitting in the United States, that has very well been the case. Of course, what we found out from our global research is that it's also the case in many other areas of the world as well. But there's so much more that affects our health beyond clinical care. In fact, clinical care is one of the smaller portions of what's affecting our health. We have social and economic issues. We have our own behaviors, what we do and choose to do and are able to do. And we have our physical environment. And when you put all of those categories together, social, economic, behavioral, physical, we start to now get outside the traditional acute care health system, and we see the real components of social determinants. These are all the things that are affecting us, that are influencing us, and often that are happening upstream way before we get to the traditional health system with an acute issue. So we have issues around diet and nutrition, access, communication and literacy, education, housing, even your environment and workplace. All of these things have an incredible effect on our health. On the next slide, we can see just one of the issues that we wanted to pinpoint from our global consumer survey, and that is not all social determinants are just, do I live in a food desert, or is there, do I live in a neighborhood that's safe to exercise in? We actually have a lot of external issues that are affecting our health that are kind of what I would call ailments of the modern age. So when we broke down our survey in terms of those that said, hey, I'm in poor health, and we asked those consumers, like, okay, you're in poor health, what are some of the contributions to that poor health? Look what's coming up here are some of our top responses: not getting enough sleep, technology, the struggle with how to use technology and how it takes up parts of our life, lack of motivation, and access, mental health concerns. So, we have to move to a viewpoint of social determinants, not just being about some of the traditional things that we've looked at, housing and nutrition and environment, but also how the modern world stresses of work. So it now affects even people who are employed and may have insurance as well. Okay, so what we want to do about it, I think I think many of you on this call know that social determinants are important, and there's been a lot of literature that says it's important, but what do we do about it? And on the next slide, that's where we're going to break down into some of the things that can be done. And part of our purpose for the research was to really put together an actionable plan based on real life examples that have worked out in the field. So what are those 5 steps? And if we go on, I can just overview those for you. Building the collective will, how do we bring people together and get them pointed in the right direction? Developing standardized frameworks so that we're all speaking the same language. Generating data and insights to inform the decision making and helping the funders and the investors in social determinants understand the return on investment. Engaging and reflecting the community. I mean, this is really, some of these are kind of built in from the beginning, that there's going to be community engagement, but there certainly has to be a checkpoint. Is this going to actually work for the community that we want to serve? And then last but not least, we actually need to measure and redeploy if there's changes that we need to make. I'm going to take us just one step a little bit deeper on the next slide. So if you kind of think about, what are some of the, actionable items that are there around each, just to give a little bit more example of what we mean by this. Someone has to be the trusted organization in the community that can be the convener. And often it is the organization that is on the hook, at risk for dollars. So in the United States, that might be payers or government or other type of community organizations, but you have to have someone who's kind of, quote, quarterbacking the team. You've got to develop a framework that everyone understands how things are going to be measured and how things are going to be prioritized. Because one of the challenges we've seen is that there's a lot of different groups sometimes that are working on these issues, and there can be a lot of confusion in terms of everyone pulling in the same direction. We're going to spend a lot of time today on how you can use technology as an accelerator for this, and why it's very, very important to leverage consumer data and focus on consumer segmentation so that interventions can be tailored to the right people at the right place at the right time. And that also helps connect interventions to what the community actually wants and what they're going to respond to. And as I mentioned earlier, last but not least, often in today's world, we have to come up with a return on investment. And I think that's something you're also going to see in our discussion with you today as we move farther into the talk and the case study, that an ROI is really important, not just because maybe there is a funder or someone at risk for payments that is interested in it, but you also want to use all of the resources as wisely as possible and have interventions that are going to provide the most bang for the buck. So with that, let's go ahead. We've hit the macro, we've hit the global, why this is important, how we can actually have steps that we can take action on. Let's now go down to that next level. Sam, I'm going to hand it off to you as you do that deeper dive on how we're going to use technology to help us do this.
Great, thank you, Ben. Yes, this is Sam, and I'm going to talk a little bit more detail about the actual, the sort of technical and modeling and data approach that we're using to actually implement some of the things that Ben was talking about. So if we go to the next slide. So our approach here is to say, given that across outside of healthcare, there is the expectation that people are being treated more as individuals and being able to be delivered personalized results in context, in the moment, within how their life works. And so our idea here is, this is a concept that exists, what is personalized health and how do you actually make health personalized? And so we're going to talk a bit about our approach to implement that and the techniques and the work that we've done, and then ultimately hand this off to Shazev, who will talk about a specific example that we did with Meals on Wheels with Chris. So our team here that we have, like you see listed, this is a project been ongoing and a long-term investment at PwC to say how do we both understand an individual's both physiological health and then their behavior and context and how do you interact with them. So if we could go to the next slide, please. And so there's a couple parts to it. So the first part is thinking about people's actual physiology and how does their health work going into the future. And this is we're thinking about things about what is people's progression of their blood sugar or their risk of cardiovascular disease from their cholesterol and their blood pressure and things like that. And so we actually have a team of biomedical engineers, applied mathematicians, computer scientists that actually developing computational biology models that we'll talk about actually in a little bit to say how do we sort of in a real physiological way predict and forecast and understand why people's health are progressing in different ways. The second part is, just knowing that someone is at risk is not all, anyone who's ever worked on this knows that's not enough to actually help a person. You have to understand what their health behaviors are, how do they sort of believe and consume and are influenced and decide to make decisions about their health. So there's a separate part about this is to understand the person not only physiologically and medically, but then also sort of more, this gets back to the holistic part to say, what is the sort of the context and their sort of behavior and belief structure around their health. And then lastly is sort of then, not lastly, but it's how do we actually put this into use and how do we help to actually, implement this, customize and sort of represent particular organizations. So we can go to the next slide, please. Okay, so with the approach we take is to say to generate a synthetic population of individual people. And so those people, we can do this a number of ways. Typically what we do is we generate a population of, say, thousands of people. And those can either be specific people that you can match up their health history to, or even privacy is a concern frequently. And so we'll have like different sort of types of people, but we'll sort of use a series of all the different sort of types of people to cover like the variance or the swath of all the kinds of people that may live in a community. From there, we actually can say, where are these people's health going? And then the interesting part about sort of representing in all these different layers of details is that instead of just saying, here's your demographics, here's a bunch of statistics about you, just based on past history and, like just sort of like the, statistics about populations, we're saying you're at risk. Rather, we can say we're simulating individual people. These people actually have lifestyles that sort of are what is their daily diet? What is their daily activity? How do they sleep? and so on, so we can actually understand how it is that they get to a health state, and whether that be a healthy health state or one where they sort of are at risk for some sort of chronic disease. We can then back out and say, how is it that they get there? And the important part about that to say is, now we have a better idea about how to intervene, because now we know the forcing factors and the causation around what's causing you to sort of move into being at risk for cardiovascular disease. The idea here then is to say, once we've identified those, then that better allows an organization to optimally focus their energy, their funds, their, what parts of a community that they work in that they can influence and sort of understand what they can do and what parts need to be done. So we can go to the next slide. Okay, so how we do? I'll walk through sort of some high-level steps here, and again, Shizev, in talking about Meals on Wheels, will make this more specific. But typically what we do is we take a region, and we can do this at a zip code or sub-zip code level. We generate, we sort of look at sort of all the kinds of people that may live in that zip code and generate thousands of sort of synthetic people to represent the diversity in that group. And then similarly, there's sort of understanding sort of behavioral characteristics of people there, and then also sort of saying what are the sort of current sort of institutional interactions that people may have with the health providers or healthcare system, or with the health insurance. Again, the idea here is to think of this as a whole system rather than isolating, just saying, oh, these people are at risk for high blood pressure, so we kind of just need to focus on that. Rather, just think about what is the whole picture about how people arrive at a particular health state. Going to the next slide. We can then say, given this population's current state, we can then simulate those people forward in time and say 1 year, 2 years, 3 years, 10 years in the future, where is the health of these people going? And who are the people who are at risk? What are the driving factors, like I was saying? And then you can also sort of start to attach, sort of what is the financial implication of the required health services that these people will need. So this is important because then you can kind of then do return on investment calculations, which is something we'll show in a moment. And then the next slide, please. Right, and so then the idea here is now to then match up these, what we know about the health of the population, where the health is going, and match that up with what an organization may have sort of, the idea is how that organization interacts with the population, and what's the best way, and what effect they can expect to have, and how do you fine-tune and specify an intervention to get as large a result as you can, and then efficiently and in a way that is, cost efficient. Okay, so I think from here, I think that's the last slide here. We can go to the next one. We've transitioned to our particular case study with Chris and Shizev to talk about specific work that we did with Meals on Wheels and VNA. Thank you.
Okay, thanks, Sam. So here we're going to go to this case study where we used technology and the social determinants of health to quantify the impact of meals delivered from Meals on Wheels has on a particular community in Dallas, Texas. So next slide. And so Chris, would you like to give an overview of VNA?
Yeah. So the Visiting Nurse Association of Texas, we're a 86-year-old healthcare nonprofit. We have gone through a number of iterations over those 86 years, but today we are primarily really two large programs. One is our Meals on Wheels program, which is what PwC looked at through the work that they did for us. We're the largest single-site kitchen deliverer or operator in the United States, so we're one of the larger Meals on Wheels operations in the country, and we deliver on average about 4,500 meals to someone's home, and then we also do some congregate or senior center feeding sites. So every day, really, the total is about 6,000 meals that we deliver. The other side of our business is we are one of the larger nonprofit palliative and hospice providers here in North Texas. So our meals program covers just Dallas County, 1,000 square miles, very urban, 27 cities within that county, of course, Dallas being the largest. And then we cover really 14 counties in North Texas. So both the Dallas-Fort Worth and all the surrounding suburbs, we cover those with our hospice and palliative program. So that's us.
Okay, thanks, Chris. And so we at PwC wanted to partner with VNA as we have the ability to really have an impact in this community. And so in this pro bono project, we use Body Logical, which is a model of human physiology where we're able to create virtual populations to simulate the health impact that a program such as Meals on Wheels can have on the health economy. So next slide. And so in this project, we wanted to quantify the impact that Meals on Wheels has on this community in Dallas, Texas. And so we know that delivering nutritious meals to the elderly is a good thing, and we know that it has a positive impact in the community. But what exactly is this impact? And so using technology, using Body Logical, we simulated the health impact that Meals on Wheels has, and we quantified what this actually means in the larger health, what this means in the larger health economy. And so through this ROI calculations, VNA can then use these data to kind of ground their donation discussions with current and future donors. Next slide. And so Body Logical is a patented, peer-reviewed model of human physiology, where we're able to do predictive modeling on someone's health. And so through the creation of digital twins, we can forecast someone's health into the future, say 1, 5, 10 years, to see how their current and future lifestyles will have an impact on their health. And so Body Logical uses a lot of different big data and different organ level interactions to accurately simulate how someone's health will change given their lifestyles. Next slide. And so in this particular project with VNA, we created a virtual population. So we created multiple digital twins that match the demographics of VNA's clientele. So we used data from VNA and from Dallas, Texas, to create this population. And now that we have this virtual population, we did extensive research on what these people eat with and without Meals on Wheels. And so we had the composition of the meals that VNA delivers, and then we also did other research to see what these people eat if they didn't have food from VNA. And through this, we did a series of simulations. So we simulated the health of this virtual population with these meals from Meals on Wheels, and then we also did the simulations without these meals. And so we're seeing how biomarkers change in the presence and absence of VNA's program. And so we see a change in biomarkers and how the biomarkers respond over time. And so when we're looking at biomarkers, we're looking at things like blood sugar, total cholesterol, blood pressure. And so with these are direct inputs into other disease states and other healthcare utilizations. And so we took these biomarkers together with different social determinants of health to see how else these meals from Meals on Wheels can impact someone's health state. So we looked at things like nursing home utilization, acute health events such as stroke and heart attack, and how the differences in these based on someone's diet. And each of these events and each of these healthcare utilizations has a direct cost. And so we developed a cost model so that we can then compare how the costs are different in the Meals on Wheels and non-Meals on Wheels simulations. Next slide. And so given these different simulations and the comparison and taking into account the actual cost of delivering meals to individuals over a year, we found that the impact that meals that VNA is having is a 61% ROI. And these are numbers that we can then dig in further to show donors exactly how their funds are impacting the community. So next slide. And so this ROI of 61 is driven by a number of things. And so I mentioned earlier the biomarkers, the changes in biomarkers based on the meals that someone eats. And so on the graph on the right, we're looking at 4 major biomarkers: BMI, blood sugar, systolic blood pressure, and total cholesterol. And in blue, we have what the distributions would be without Meals on Wheels, and in red, with Meals on Wheels. And we're seeing a shift to the left with the Meals on Wheels population showing an improvement in health. So we have a reduction in uncontrolled diabetes, a reduction in high blood pressure and in high cholesterol. In this particular community, malnutrition, which is what Meals on Wheels is trying to fight, is largely driven by sarcopenic obesity. And so we're seeing a reduction in obesity in this population due to the presence of meals delivered by VNA. Next slide. And so these biomarkers, together with other social determinants of health, have a direct impact on other healthcare utilizations. We're seeing a reduction in hospital readmissions, a reduction in skilled nursing facility utilization, a reduction in malnutrition, and this goes to show that DNA is having the impact of allowing the elderly by allowing this population to stay in their homes longer, to stay healthier in their homes longer, and giving them that independence. Another big factor that we're seeing here is a reduction in loneliness, and I'll let Chris comment on this a bit.
Yes. So one of the things that we've recognized certainly over the time frame of doing the actual meals program is certainly the nutrition piece is very important, that you're delivering. We deliver our meals at lunchtime. It's a hot, nutritious meal, and the person gets that delivered to them. Really, though, one of the things that we've not only learned in this study and in some others, and just sort of from our own just knowledge of the program, is that it's that loneliness factor that we really sort of help deter, in a sense, because someone is visiting that client of ours every day, whether that's a volunteer or one of our paid employees who's doing those routes. And so we've learned that if you're on Meals on Wheels, you know that between the hours of, say, 10:30 and 12:30, someone's going to come knock on the door. And so you have to kind of get ready for that, that you have to, someone's going to come and check on you. And so a lot of our clients live alone. A lot of them, the only person they may see every day is that Meals on Wheels driver. And so that reduction in loneliness is a big factor. And I think it sort of goes across some of these other determinants of health when it comes to things like readmission rates into hospitals after someone has come home from a hospital stay. Is someone checking on them? And having those drivers just knock on the door and ask them how they're doing is a big part of that. And so that loneliness piece, we feel like, is a big part of what we do. Some of the healthcare partnerships that we've created over the last couple of years, where we're taking high-risk patients from health systems here in Dallas, they're referring those high-risk patients to us. They're paying us for the meal and they're paying us for that daily safety check. All of them are very keen on the fact that we're going to be delivering a nutritious meal to that client or their former patient. But a really big part of it is that you're going to knock on the door and check on that person every day. And that helps sort of reduce that loneliness factor. It sort of helps us, it allows us to check on that person. And those clients know someone's going to come and see them. So that's a key, I think, a key part of what PwC was able to sort of show the difference between people that are receiving meals and people that are not.
Okay, great. Thank you, Chris. Next slide. And so we see how people's health has changed, and we see the 61% ROI, and we see this reduction in loneliness. So what does this really mean for the larger population? And so in our findings, we found that it led to a 7% reduction in healthcare costs in Dallas, which is huge considering that these costs are in the millions. So without Meals on Wheels, we're looking at a $164.3 million healthcare cost. With Meals on Wheels, we see that reduced by $11.3 million, and this is due to to improvement in health status for those suffering with chronic conditions. We see a reduction in acute events such as heart attacks, strokes, congestive heart failure. We're seeing a reduction in skilled nursing facilities, utilization, which carries a heavy cost. And so here we're able to quantify the impact that VNA is having in this community, which is a tangible thing that VNA can then go to donors with and show exactly, what is being done in the community. And so I'm going to pass it over to Chris for him to discuss more about how they're using these numbers with their organization. Next slide.
Thanks, Chavez. So, I think for us as an organization, we've always sort of understood the sort of intrinsic value of a meal being delivered to somebody. It's essential for life that they're getting the food. It's the doing good part in the community. Again, we're one of the larger Meals on Wheels operations in the country, and we're providing meals to a lot of folks that need it. I think the harder part for agencies like ours is to sort of talk to on the level of what does it mean beyond the service to that particular client. So our mission as an organization is to provide care to those people and to bring them that meal and to check on them. At the same time, since PwC came to us and helped us work through these numbers and sort of show us the difference between what the health of someone that's on meals versus the health of someone that's not, what the difference in healthcare costs and healthcare savings for that particular person is, and really what the overall healthcare savings is for the greater community. Now we're really able to talk on two sides. So we're able to talk about the intrinsic knock on the door, here's your meal, how are you doing part, and we're also sort of being able to tell both funders, the community, our volunteers, institutions that we're working with on really garnering support for our program, are really helping us make sure these clients are staying in their home, is now we're actually being able to quantify what it means to deliver a meal to someone and what does that value of that mean. And in our industry of healthcare, we all know that it sometimes comes down to how is this program going to help me serve patients, make people healthier, but also how's it going to reduce costs. And so that's a big part of how we use this data. A second piece was really being able to show that the impact on the community as a whole. And so, people that organizations or individuals or so forth from a fundraising standpoint, and certainly as a nonprofit, we raise dollars to help pay for these meals. But from a fundraising standpoint, when you're able to talk about that the money is going, your contributions in a sense are going to support us to allow us to deliver that meal. But on the other side of that, we're having a greater impact on the community as a whole from a healthcare benefit side. You can actually show them the information, put the numbers in of what certain types of gifts will equal to a savings on the healthcare side. What their investment will save, I think, has been huge. We in particularly have used this not just in a broad sense, but we've actually used this in direct asks, particularly to larger contributions. We had two very large gifts for us as an agency. We're about a $35 million nonprofit, which is pretty large, but we had two gifts that came in last year. One was $2.5 million, and one was 1.6, in particular to help take people that were on a waiting list to receive meals. And we used this information that PwC did for us to show those two institutional foundations. Your investment will not only do the feeding part, will not only allow us to make those meals and deliver them, but look at the impact it's going to have on the healthcare community. And both of these foundations not only supported social service organizations or social service programs like meals, they also supported a lot of the health systems in our region. And so they found that super particularly interesting, and they were very engaged in that piece of it. So, next slide. And two, part of the way in which we're using this, and if you were to go to our website, you can see a couple of these slides that talk about this, and we use this in not only asking donations. We use this sort of way to sort of just talk about the agency now. We've kind of shifted a little bit away from just talking about the intrinsic piece and talking more about the value. But for us, it always goes back to the client. And so if we can marry those two messages together, we can say, here's the client, here's a story about that person, here's who they are, here's a little bit about, where they live and what they do every day, but then also sort of showing that supporting this program will support this particular person, but it'll also have these quantifying impacts. I think has been, for us, a powerful message, not just to donors and to volunteers and people that already support us, but it's the ability to go out and show others the impact of that. So that's been super important. Next slide, please. Also, what I think has really sparked at least our interest in sort of looking at data. I think we've always had to. We as I said before, we're a palliative and hospice organization, so we have to do reports to Medicare, Medicaid about the work that we do, and so there's a lot of data pull here. There's a lot of really smart people to do that. However, we've never really looked at all of the data that we have around our social service side for Meals on Wheels. We've been a reactionary organization in the past, which a lot of nonprofits that have a social service arm are, but we're really looking at how do we become more prescriptive in the sense of how do we use data to go out and make decisions on how we go in certain directions. And so two of them in particular kind of come out. This was certainly something we started thinking about after we did this project with PwC, as we really dug in to see how long clients are actually on service with us. And we had looked at this before. We had anecdotally thought that it was more around 5 years that a client would come on service today and would be with us for 5 years. That was sort of an average thought. When we really started digging into the data, it really came out to be around 27 months, so a little more than 2 years. Being able to show the data and the work that PwC did in the sense of saying, hey, here's how you're saving the community and you're saving those people that are on meals from a healthcare standpoint. But then for us to overlay and say we now realize or now know that in looking over the last 10 or 15 years that it's a 27-month time frame, we're actually then to restructure the way in which we raise funds or raise investments towards this program. And so we have those two things that are going. And so that's been unique and certainly helpful for us. Another piece for us is, we have a large healthcare side and we have a large social service side. And they have worked, those two groups have worked together, groups or departments or however you want to call it, programs, have worked together before, but not as closely as I think a lot of us here would like to see. And so one of the things we have begun doing is to really dig into visiting with our meals clients and talking to them about who are who are they using as their healthcare entities? How are they accessing healthcare today? What are some of the other obstacles that are in the way for them to access care? Is it transportation? Is it doctors, whatever in their community and so forth. And so we're using and beginning to think about how do we ask those people who are their primary care physician and who do they primarily go see. What happens when you do that, of course, if you think about a Meals on Wheels population, is a good percentage of those folks say they use the hospital or they use an emergency room as their primary care physician. And by knowing that, we're able to then work with our partners in the healthcare system space to say, we have this many clients that are using you or have told us they're using you as their primary care physician. How can we work together to sort of reduce some of the drag on your system or emergency room visits or unintended admissions into your system, at the same time, knowing that those organizations, as Ben sort of mentioned earlier, everybody in the healthcare world is looking for how do we address social determinants of health, where we can use data up front to say, hey, these are your clients, these are your patients, these are also our clients. Let's work together to find a great solution. So next slide. And then I think this is kind of, the final slide to the presentation. It talks about, I think when groups do presentations and they don't sort of say, how can you make the data work in a sense for you? I think for us, again, we begin on our side of the work. We begin sort of asking those clients who their physicians are, who their providers are, starting with the small questions to collect data that's easily collectible. For us, a big part, almost all of our data that we collect is self-reported. And so that's an obstacle sometimes, because if you ask them who their doctor is and they say Bob Smith, well, there's 80 Bob Smiths in Dallas, and so you have to kind of figure out which one of those is the right physician. So I think that for us, being able to answer some basic questions that is, it allows us to be able to capture, look at, run, and sort of think about what are some of the ways we can use that is really a great next step for us. And as an organization, we've really dug in the last year to look at how we're collecting that data, where we're storing it, who has access to it, what are some of the questions we're asking and why, and are there other tools out there that, in particular, that we can ask questions of our clients today, and 6 months from now or a year from now, ask them the same series of questions and see some change in condition. For us as an agency, our clients are elderly. They have 5 chronic conditions. They live on less than $1,000 a month. They're not going to get healthier per se. They're not getting better. But can we reduce loneliness? Can we reduce food insecurity? Yes. And so we're really crafting some of the questions and things that we're going out and talking to our clients about, asking them questions that are related to, does this program help these things, versus some of the other questions that we've always asked around nutrition and risk scores and things of that nature, which as a person ages, their risk levels for certain things go up. So that's kind of how we would suggest other groups use the data. And Chavez, that's all I have.
Okay, thanks, Chris. Can we go to the next slide?
Hi. So we are finished with the presentation. I just want to thank our presenters for just an amazing presentation, and really hopeful with some really good SDOH initiatives. We have tons of questions, and so let's go ahead and get started with them. We might not be able to finish with all the questions, but maybe our presenters would be willing to follow up with you. So what is the share of people struggling with the new SDOH factors compared to the traditional ones, such as food desert, access, et cetera? Seems like there may be some health disparities there. So I'm not sure who to.
Yeah,
go ahead.
This has been. I'm happy to start with that. So that's actually from our HRI research report, and those responses are from our global consumer survey. I don't have a breakdown, for you right now on the phone in terms of, nutrition versus some of these, issues around sleep and technology and things of that nature. What I can say though is that these are people who are these are consumers from around the world that are self-reporting that they are in poor health or very poor health. And we asked what were the top barriers for their health, and these are some of the ones that came up. And I think the other interesting thing about this, because it's a global survey, we are picking up countries which actually spend a lot of money on social services. So unlike the U.S., where we spend most of our dollar on acute care, healthcare, and a very small portion on social services. Don't forget, some of these consumer surveys, I mean, it's Canada, Australia, Germany, where it's really almost flipped from the US. So a lot of things like nutrition and housing are being taken care of, in a place like Germany. But you still have these barriers which are kind of ubiquitous. They're around technology and things of that nature. So I don't have the exact breakdown for you right here on the call, but just want to give you that additional information.
Thanks, Ben. Another question is from a purely clinical or financial standpoint, I can see how this could be tremendously helpful. However, does the model take into account bias, racism, inequity, and ensuring interventions are made in an equitable fashion?
Yeah, this is Sam. I was reading this question. We were kind of talking a bit about how to answer this. Obviously, this is a problem that needs to be focused on, and we won't claim to have to solve this. But I do believe that treating this population as a collection of individuals allows us to then say, even if you have a subgroup or a sort of subgroup of people within a population that's very small, and traditionally you might say, I'm going to optimize my intervention to get the most effect for this population. And what can typically what can happen is that small group becomes sort of, it doesn't, for whatever reason, whether it's accessibility or it doesn't actually address their health needs, they kind of do not benefit from it. So what you can do here is say, for different interventions that you may propose, you can then take and say, for that particular group, and however you want to classify that, or identify them, say, how is this intervention actually going to help them, and how is it going to help this other group and help this other group? And so in that way, hopefully, you are able to design an intervention not just based on what's the single thing that helps the whole group in aggregate, but you can actually say, I have a particular concern about identifying and working to increase the health of a particular group. And so you can kind of look at your interventions, you can sort of develop a portfolio of interventions that then address that level of detail that you may be concerned about. Okay.
Thanks, Sam. Any other comments from the panelists? Well, let's go on to the next one. Are you getting any responsiveness and traction with health plans and care delivery systems based on the modeled ROI or actual ROI?
Yeah, I can take this one again. So this model, we use the same model in this similar process in a number of different places, right? And so, of course, we were looking at the social determinants here, and the same to social determinants of health, and modeling them and understanding interventions are of interest, to payers who are looking to interact with consumers and patients directly, to better understand and to influence and increase health, ahead of when issues occur. And then similarly for, providers to then better manage and understand and similarly influence the health of the people who are likely to be coming to them for health services. And so, this same approach to understanding ROI of, either existing programs like Meals on Wheels, which have this long history and sort of, people have, exists in the social consciousness, and within additionally, new programs that there may be research on from, one city in the country, and people want to understand, how would that then, work in my community? And so, there's a generalization of new kinds of programs, existing programs from other places, how does it translate into other communities? And then, within the healthcare system, what are the benefits to the different players in the larger ecosystem?
Thanks, Sam. And these two questions are sort of similar. It's about really tracking the numbers. One is about able to track the reduction of hospitalizations of MOW enrollees, and one is about just the variability and things happen. Does that impact the numbers? If there's weather, transportation, for example. So it's really about correctly, or not correctly, but accurately tracking some of these numbers for predictability.
Yeah. So this is Shizav. So in terms of tracking the reductions of hospitalizations, when we created a health state model, which we use publicly available data of the incidence and prevalence of certain acute events like strokes and heart attacks. And so when we calibrated our model, we validated to make sure that it was providing the expected outcome for the population at that point in time. And then with that, we're also able to propagate that into the future. And so when we run our population through this model, we did it with and without Meals on Wheels. And as your diet has a direct impact on your risk of having a stroke or a heart attack, we're able to calculate the difference in those numbers with and without Meals on Wheels.
Any other comments from the from the panelists? Okay, well, can this model interface with health information exchanges and perhaps even be incorporated into value-based payment models?
Yeah, so it's an interesting point. And so that is, that is something we're working towards in establishing, ideally, we believe this model obviously is very valuable, and, working towards having, whether it's this model or, some other model that actually uses the actual health of individuals, being able to forecast health based on, all the things we know medically, and sort of have this all come together in one place to better, ultimately price and sort of design healthcare systems to operate efficiently is an ultimate goal of ours, and that is something we're working towards. That's right.
This is about loneliness. I don't know if this is directed to Chris, but you noted reduction in loneliness. How was it measured, and was there a dollar value assigned to that reduction?
So I can actually take this question. So okay. There are different models to measure loneliness, and there's a lot of research on the impact that Meals on Wheels has on loneliness. And so with these models and that research, we were able to incorporate this into our larger health state model. And there is no direct cost on loneliness itself, but loneliness plays a part in a number of other health conditions. So loneliness feeds into skilled nursing facility utilization. It leads into dementia. There are many different factors that do have costs, and so while there's not a direct cost associated with loneliness, it does impact these other healthcare utilizations.
Thank you. Any other comments?
Yeah, this is Chris. I mean, certainly from a numbers standpoint, I'm going to leave that up to the experts, but just from our partners in the healthcare system that we work with, again, I mentioned earlier that we have some partnerships where they send us higher risk patients who have a readmissions score that says they have an opportunity to come back to the emergency room or readmit unintendedly. We have quite a few of those, and we work with 3 health systems here in Dallas that are telling us that a good portion of some of these higher risk patients will actually just walk back into the emergency room from time to time because they're lonely. And so again, you don't know that that's gonna, what the cost of that, say, loneliness piece is, as Chavez says, but just from their observation standpoint, when we talk to these systems, they're all very interested in the nutrition side, but they really do pull their chair up a little closer to the table when you tell them, I'm gonna put eyes on a person every day. And that sort of knock on the door and that how is that person doing and checking on them is equally important, we feel, as the meal itself, because that is truly that social nutrition piece that I think with a lot that has come out of probably what's come out of a lot of the numbers in here is that, yes, it's the nutrition piece, but I really do have a feeling and just doing this for so long that I think it is really a big part of it is that loneliness piece. And so health systems out there, of course, are looking at ways to how do I create infrastructure, whether that's community social workers or community health workers to actually go out and interact with patients on the Meals on Wheels side. And I'll probably just speak for every one of us in this business is that we already do that. And so partnering, again, Ben talked about having, the convener as the health system and finding that right agency. In this particular model, finding that right group to kind of go out and say, how can we partner? Because we do something that you guys can't do, or it would cost a lot of money to stand up to do. Let us help you with that. And so that's kind of how we've grown some of our healthcare partnerships using this data.
Thank you. So one last question. I know our time is almost up, but let's try for one more. And this is very clever use of bridge analytics to link SDOH to clinical outcomes. Does your digital twin model require any clinical data variables? And if not, can SDOH data alone go down to the one-on-one level or less precise cohorts?
Yeah, it's a good question. So the way we've designed this model is to be used in situations like this. So, obviously, we can use the model sort of at a sliding sort of like sort of amount of information. And, you know, the idea is the more actual clinical information we have about a person, you know, the better our results and the more we're allowed to, the more we're able to sort of infer the subtleties of how their health progresses. So, you know, the way we used it here is we didn't actually have clinical information about the individual clients at Meals on Wheels, but we did have information about their demographics and sort of, you know, their age and the fact that they're in the program allows us to then backfill and say, we know, like, across different, usually government data sets, to say, we can go and find a nearest neighbor or twin, you know, within sort of different data sets that do have that missing clinical information, and we can then do our best guess to backfill that in. You know, then if you do have someone's actual blood pressure today, then that model gets more, you know, model gets more accurate. But we've designed it so that, you know, you can run it off of, you know, someone's sort of age and gender, and we can fill our best guess to all the rest of your health information, you know, all the way up to, you know, here's all your health records for the past 5 years, you know, and then sort of integrate those data in that way. And then the model gets more accurate the more data there are. So it's not the exact, maybe, you know, sort of a non-answer in many ways, but the idea is that we use this model in a lot of different levels of data availability.
Thank you. Well, it is the end of the webinar time, and we've got lots of actually questions that weren't answered. If you'd like your questions answered, shoot me an email, and I'll see if I can follow up with the presenters and get them answered. So it's claudia.ellison@ehidc.org. So I want to thank the presenters for just a fascinating presentation. I mean, it was really, you know, hopeful to see the ability to use social determinants of health for such, you know, important work in improving healthcare. So, and I also want to take the time to, again, you know, thank PwC for their support, and also thank you to the attendees for today's webinar. So I wish everyone a good rest of your afternoon. Thank you. Take care. Bye-bye.
Thank you. Bye-bye.
Thanks. Bye.